They get compensated in other ways. My glasses had been lost for months and months, and all of a sudden I found them. Now I can see again. Hey, everybody.
Hello there, Cynthia. How are you?
Hey, Dr. Bell, how are you doing?
Doing good, doing good. I don't see David on here.
Sherry's coming.
There he is. All right. So, David, I think we have, I know we have a quorum now. City Manager Motwani. So, I can get this meeting going. Good afternoon, everyone. Today is April 14th, 2021, and it is 1:00 p.m. As a quorum of the committee is in attendance via our video conference, I'd like to call to order the meeting of the Central Health Strategic Planning Committee. Our first item of business is public communication. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via an online form or by telephone no later than 11:30 a.m. today. Yvonne, did anyone register to make comments?
Hello, Mr. Chair. Yes, we do have 2 people registered to make comments. However, I don't see them signed in. Would you like me to proceed with reading the guidelines or wait?
Why don't you go ahead and read the guidelines, and then we'll see who comes in, and then if necessary, we'll pick it up. We'll start an agenda item and then pick it up later in the agenda.
That sounds good. Okay. To be recognized to speak, you must request a speaking slot using our public communication online registration form or by leaving a voicemail 60 minutes before the meeting. Individuals are asked their preferred language as they register to speak, and both the online form and voicemail greeting are in English and in Spanish. All speakers will be recognized by name and in the order their speaking request was received. We ask that you keep your device muted until you are called on to speak. Please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will be announcing when a speaker has reached their time limit. We will allow 30 more seconds to wrap up their comments before they are muted. Due to the restriction of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may also, or the committee may also choose to set aside any new issues for discussion at a future meeting. And the first person is Claudia Zapata with the Del Valle Community Coalition. and I'm not sure if she is signed on. I don't see her signed on, and I don't see the second person signed on either, Mr. Chair, unless the person signed on via an iPhone is that person. The other person is Paul Saldaña with the Austin Latino Coalition.
Okay. Well, what I'll do is when they join, hopefully I'll be able to see their square, and I will have their public comment after we finish an agenda item.
Okay.
Okay?
Good. Perfect.
Thank you,
Thank
Eva.
you.
Appreciate
Absolutely.
it. Okay. Agenda item number 1. Review and approve the minutes of the March 10th, 2021 meeting of the Strategic Planning Committee. Do I have a motion? I have a motion from Manager Valadez. Do I have a second? I have a second from Manager Matwani. Any discussion? All in favor? Aye. Any opposed? Any abstaining? Motion carries. Agenda item number 2, receive an update from the Central Health Equity Policy Council's Pandemic Equity Committee. And Megan Cermak will be presenting. Thank you, Megan.
Thank you. I'm just going to wait for my slides to be pulled up. It looks like they're coming online now. Okay. Thank you so much, everybody. I'm Megan Cermak. I am the Director of Public Health Strategy, Policy, and Disaster Response at Central Health. And I also lead our Central Health Equity Policy Council. Next slide, please. I know that we have some new board members on the meeting today. So at a very high level, I'd like to just brief you on the Central Health Equity Policy Council. We use the term council and coalition interchangeably. We are a coalition essentially that launched in 2015. We have more than 80 community partners. At a very high level, we work to address health disparities in Travis County by pushing policy forward regarding health, healthcare, and the social factors of health. We decided about maybe a little less than a year ago, Mike Eastling asked a focus group, the Central Health Equity Policy Council members, on what an equitable pandemic response would look like. In retrospect, I think it's funny that we thought we could only have one conversation with the Policy Council members regarding this topic, because after the focus group, we kept talking about it in one-off meetings and then in smaller groups. The conversation bled over into larger committee meetings. And so finally, we just decided to launch a formal committee to look into pandemic equity in December of 2020. So about 5 months ago. When we launched the effort, we didn't really know what the end goal was going to be. However, I think where we landed is we are experiencing problems here locally that are not unique to us. They're the same problems that we're seeing across the state and across the nation. However, we think that we have a unique opportunity to capitalize on our strengths and focus all of our future disaster planning and response efforts on equity, capitalizing on the strengths of our community. Next slide, please. Before I move forward, I just want to recognize all of the people who put so much work into the recommendations that I'm about to speak about. And some of them are on the phone here with us today, so I'd also like to recognize their time. So please give me a couple moments as I talk about each member. The members of this committee have put in approximately 200 volunteer hours in looking into these recommendations and addressing other community concerns, and that's why this is so important. The members of the committee include Brandon Wallerson. He formerly led up Community Care's David Powell Clinic. He's now with Texas Health Action and on the LGBTQI Commission. Catalina Berry, she's with the American Heart Association, as well as her colleague, Emily Zhang. Ileana Gilman, I believe she's on the phone with us today. She was the former ED of El Buen Samaritano. Now she's with HMA. Kristen Dubé Horton, she was the former health commissioner in Bridgeport, Connecticut. She is a community organizer for the Black and African American community, and she also is a community organizer regarding youth and mental health topics. Matthew Jeans is a PhD candidate at UT. He put in countless hours of data research into the recommendations that I'm about to bring to you. Nora Comstock, also a very well-known community advocate. She's also on the board. She's an ACC district trustee. She's very involved with Comi Madre and a tireless community advocate. Patricia Hayes used to be very involved with the Texas legislator, former chair of CAN, former board chair of CAN, former board chair of the Black Chamber of Commerce. Raul Alvarez, I believe, is also on the phone with us today. Raul serves as an equity advisor to our entire community and specifically the mayor. He's the ED of CAN. Vanessa Soria, she is the ED of Cardia Services, and they provide education to community health workers. And Vince Cabalas. Little known fact about Vince is that he was my former boss when we worked at the city together. And since his retirement, he's been serving on the Asian American Quality of Life Commission. Next slide, please. Okay, so this beginning introduction is of no news to anybody, and that is that this pandemic has shone a light on the inequities that people of color and other marginalized populations experience daily. In our research, when we talk about marginalized populations, we focused on families that are affected by domestic violence, seniors, people with low income, people who are uninsured, underinsured, people with IDD, or I'm sorry, intellectual development and delays and disabilities, people with behavioral health issues, people with mental health issues, and people with substance use issues. The tone of our recommendations and all the products that come out of our recommendations are very much so that we want to recognize and appreciate the efforts that our city and the Emergency Operations Center has put into the disaster response so far. We would like to partner and collaborate with the city and the Austin on making sure that all efforts as we re-enter our society in this post-COVID world and in all future disaster planning and response are centered on equity. And we know that we as a city are not going to fare better in a disaster until our most vulnerable citizens or our most vulnerable residents fare better in a disaster. Next slide, please. So I want to talk about how these recommendations came to fruition. First and foremost, we interviewed people on the front lines, and I would be remiss if I did not recognize my colleagues, Sarah Cook, Vanessa Sweet, and Yvonne Davila for the time that they put into interviewing the frontline workers. Specifically, we focused on the community care staff who were setting up the testing sites and providing care in the clinics during those very early days of the pandemic. When things were really scary, we didn't have enough PPE, and we didn't know how the virus was transmitted. We also interviewed our LGBTQIA healthcare providers, who from the start were raising the red flag that they were seeing a backslide in people seeking sexual health services. And now during this legislative session, we're facing a $54 million budget cut in HIV-related social services. We interviewed the leaders of the Emergency Operations Center, the directors of the social service branches, that where early on, that's where sort of the equity part of the response was first centered. However, it later was moved forward higher up in the incident command structure, which we'll talk about. We gleaned a lot from the Asian American Resource Center, and very briefly, I just want to talk about the AARC. They play a very unique role in the Asian American community here in Austin. So they are a cultural arts center that fall under the Parks and Recreation Department, very similar to the MAC. During the pandemic and the winter storm, the AARC played a very pivotal role in getting translation service out to the community. And they also played a very critical role in making sure that information and resources were being pushed to the immigrants and refugee populations. We spoke with the City of Austin Human Resources Department, which is where their equity, diversity, and inclusion staff are housed, and the City of Austin Equity Department. And then ultimately, this kind of accumulated in a private tour of the EOC, where we were able to kind of go over bullet point by bullet point some of our concerns and learn more about the EOC and the incident command structure. We also interviewed our community health workers who played, a critical role in this pandemic response. Specifically, we got feedback from the community health workers at Cardia, and then internally within our own enterprise at Community Care and Central Health. And moving forward, before we do anything with our recommendations, we are trying to get with the community health workers from ACHI. Okay, next slide, please. We also, one more, thank you. The Austin Latino Coalition and the Black Leaders Collective, we were able to get recommendations from the concerns that they put forward to Central Health and to the city, both verbally and in writing. We also used a data-driven approach where we interviewed the epidemiologists from APH and DSHS. We looked at the calls to Austin 211, and CAN played a pivotal role in analyzing the call data from 211. And then finally, we were informed by industry leaders like Robert Wood Johnson Foundation. Okay, next slide. So all of our recommendations are kind of housed under 3 umbrellas. First, disaster preparedness, disaster response, and then this post-disaster healing. Next slide. So the first umbrella I want to talk about is disaster preparedness. I want to just take one moment. I know that there are a lot of people, both board members and staff, who make sure that this meeting runs tightly and on time. And so I just want to give you all the heads up that this first recommendation has quite a bit of content underneath it, but the rest of the other recommendations I won't be spending nearly as much time on. So let's talk about this first one, which is making sure that the City of Austin Emergency Operations Plan, number 1, is an evergreen document, and number 2 is centered on equity. So the last time that the City of Austin Emergency Operation Plan was revised was 2016. That's over 6 years ago. The City of Austin, Homeland Security and Emergency Management is responsible for developing annexes and updating the Emergency Operations Plan. Really, the guidance is only every 4 to 5 years. Since that time, we know that we as a city have experienced numerous disasters, including the final wrap up of the Onion Creek floods in 2013, Hurricane Maria, Hurricane Harvey, the water crisis of 2018, the Winter Storm Uri, and then obviously the pandemic. The EOC does do a pretty good job of after action reports and publishing those after action reports online, but that's never reconciled with the Emergency Operations Plan. And so what I'm trying to say in a very long-winded way is that the lessons learned from each disaster are not being captured in our emergency operations plan, and we keep making the same mistakes over and over again, and the same populations continue to suffer from that. Moving forward, as we work on updating the City of Austin Emergency Operations Plan, they have to be centered in equity, and that has to be pushed through by the standard operating procedures of the plan. And we need to make sure that the most vulnerable populations are accounted for in all future disaster planning. And this includes ensuring that all the SOPs that are developed or revised are through an equity lens and then validated by the community. Following each disaster, I talked about this really briefly a second ago, but the EOC has this practice of doing an after action report. Essentially, they gather all the departments that were involved in the disaster and ask the same 3 questions. What did we do well? What did we do wrong? And what could we have done better? We are calling for the inclusion of a 4th question, and that is, did we solve for those most vulnerable? And we are also calling for the EOC to take this after action exercise and bring it out to the community and ask those same 4 questions. And then ultimately make sure that all of this information is made public. Next, under this umbrella is, I want to talk very quickly about the Hazard Risk Index. This serves as the basis for the city's hazard mitigation plan. This essentially drives all planning efforts. So hazards are prioritized based on 2 factors, the probability of occurrence and the potentials of dollar losses from each hazard. We are calling for an update to this risk index and make sure that it's centered in equity on the prioritization model. One example of this, and one that is extremely timely, is that neither the risk index nor the plan currently address civil unrest. And this is of utmost importance because we as a community are going to be responding to the murder of Dante Wright and to, as we end the trial for the murder of George Floyd. Next, the updated plan should include an SOP that utilizes the Center for Disease Control's Social Vulnerability Index as baseline data. And we also need to encourage we also need to engage the city's demographer for all decisions that are made at the EOC and incorporated into the incident command structure. We were just on a call recently, right before this call, so a noon call with the EOC where UT talked about that if we had used the Social Vulnerability Index in allocation of vaccines early in vaccine distribution, there would have been, we could have decreased preventable hospitalizations significantly. Also under this recommendation is following the Onion Creek floods, Go Austin, Vamos Austin, which is a community group, developed its own plan of evacuation and action in the event of future disasters. And it really taps into the strengths and the natural networks of the community. This plan was adopted by the EOC, and GAVA is now a trusted community group and a resource for the command staff. We feel like this model could be learned and replicated from, and specifically in the areas that are identified by the Social Vulnerability Index. Okay, moving on to the next slide, please. Okay, we need to improve data to more quickly respond to people of color and other marginalized populations. And by this, what we essentially mean is we need an army of people at the EOC and the City of Austin who understand the importance of collecting demographic data. We need to engage translators, interpreters, and culturally sensitive and affirming workers to collect better data. And finally, we need to tackle the implicit bias that occurs in the number one, our existing data tools, and then the analysis of data. Those are some recommendations here locally for better data collection, but ultimately as a state, we are calling for the reestablishment for the Office of Health Equity, also known as the Center for Elimination of Disproportionality and Disparities, that falls under DSHS. Okay, next slide, please. One more, please. Go back one. Disaster response, here we go. So we want to recognize that the EOC and the City of Austin really did try to capture, I think, the community voice in the incident command structure and have representation at the EOC. They incorporated the equity office into the incident command structure. They also had the diversity, equity, and inclusion HR manager for the City of Austin lead one of the social service task branches within the EOC. And they're also planning to incorporate the chief resiliency officer into the incident command structure. And that's all good work. However, through our interviews, we kept hearing the same thing, and that is that we're missing the community voice within the incident command structure. And so what we're calling for the city to do is to make sure that the community is represented at the highest level of the incident command structure, and that person or that group of people or number of people, number one, they need to be people of color. They need to represent the marginalized communities. They cannot be City of Austin or DSHS employees. We need them to be on the ground, nimble. They cannot be weighed down by bureaucracy, and they have to be able to speak freely. Next, we're calling for a behavioral health to engage behavioral scientists and have uniform public-facing education and communication efforts in times of a disaster. Our own communications department engaged with the behavioral health scientists early in the pandemic and changed the framework of all communications going out from kind of fear-based and onus on the individual to more culturally sensitive and affirming messages by working with the behavioral scientists and messages of empowerment, how you can protect yourself and your family. And so moving forward, we would like to see that scaled up among all the partners. Okay, next slide, please. Post-disaster healing, I apologize, I have to read this word for word from these notes because this is not my area of expertise. And I think that one of my policy council members, Vanessa Soria, was very eloquent in writing this. Essentially, we need to develop a trauma-informed community-wide plan to address the trauma and call for healing during re-entry and recovery that uses a strengths-based service delivery approach. It's grounded in an understanding of and responsiveness to the impact of trauma. It emphasizes physical, psychological, and emotional safety for both the providers and survivors, and it creates an opportunity for survivors to rebuild a sense of control and empowerment. And then our final recommendation, we are seeing this we have data from a national level. Our 211 calls support this. And then specifically our community health workers are saying that the domestic violence that our families in our community are experiencing, specifically our Latino families in our community, is on the rise, almost at unprecedented levels. And so what we are calling for is to promote a multidisciplinary collaboration to assess the widespread impact of trauma from domestic violence, recognize the signs and symptoms of trauma from domestic violence in clients, families, staff, and other community members, collectively respond and support the community using trauma-informed approaches, inform the development of trauma-informed policies, procedures, and practices. And as part of this, we have to continue to monitor the hotlines for trends in domestic violence and determine where support is needed. And ultimately, we need to develop a countywide plan to address domestic violence and resource it appropriately. Okay, next slide, please. One second. Sorry, my Ring Central is being just a little bit wonky. Okay, so our next steps. Number one, we want to continue to go around and talk to community-based organizations, coalitions, and commissions to see if they agree with these recommendations and findings and if they'll support us in this work. Ultimately, we'd like to support these recommendations and findings to City Council and the Commissioner's Court. We'd like to follow up with meetings with our elected officials. What I presented to you is like a 5 to 10 year plan. It's huge. But we do need to prioritize some actions. So number one, we are entering into this period of recovery. And so we need this trauma-informed plan. So that's priority number one. And then number two, we are also quickly entering into a post-disaster world where those after action exercises are going to start being taken. And so we would also like to prioritize the incorporation of that fourth question about solving for the most vulnerable and bringing the evaluation out to the committee. And then finally, we'd like to recognize our partners for all actions taken that center all future disaster planning response efforts on equity. And that's it. Thank you.
Okay, Megan?
Yes.
We appreciate that presentation, extremely informative. I would like to ask now if we have any board members that have any comments or questions with regard to that. Manager Valadez.
Thank you, Megan. And I want to make my comments, and I want everybody to understand that I mean no disrespect. But after hearing this and not seeing a written presentation, first of all, I'd like a written presentation presented to me. I don't want to hear what's being said. I want to see the words on paper. Second, I thought this was going to be an equity policy council. To me, an equity policy council means that you have members that are representative of the demographic that we serve. That's a central health equity policy council. It's as simple as that. We had this conversation when we were first talking about it, and I remember saying that it needs to be representative of our population. I am looking at nothing but administrators and bureaucrats, and I do not see people from the community. I'm going to finish, please, Mike. I don't see people that are at the level that have been the hardest hit and experienced the worst of any disaster of historically racist and institutional policies and practices. And so I was under the impression that the Policy Equity Council was going to talk to us in terms of what we need, what we need to do, what strategies needed to be implemented for us as central health and to at least be able to improve the situation so that we don't have these huge inequities and disparities. So I may be mistaken about the change in focus, because Megan, you did state after you started your conversation that Mike had gotten to you and asked how we were doing in disaster responses, which I understand greatly, because having worked those floods and worked with a team, George Morales, Rick Zavala, all kinds of people in developing responses to FEMA and to the disastrous responses that they had to our community, you know, nothing went anywhere with the city or the county. And this is going back maybe 10 years, okay? So this is, I appreciate what you're presenting to us, but not seeing anybody at the table talking in terms of what they would see as necessary recommendations to improve the equity situation at Central Health is disconcerting to me. Now, if we're going to call this something else, then let's call it the Disaster Relief Committee. But let's not call it the Equity Policy Council for Central Health, because it is not. So I have some more comments that I will be submitting in writing to you, Mike, and to Sherry, so that we can have a conversation to talk about this. And if I have to ask for it to be put on an agenda item, then that is what I'm doing right now. I will refrain from saying anything else, but I will put my comments in writing because I have a lot more to say.
Thank you.
And I'm especially concerned about the fact that we're talking to the equity officer and his staff who have been so disrespectful to our Latinos in the community for years. So I will say that. Thank you.
Thank you, Manager Valadez. Mike, did you have any comments that you'd like to make?
Yes, Mr. Chair, I do, but I think it's probably important for the other board members to get their comments and questions out. And if you wouldn't mind coming back to me, because I'd like to address some of those things that were just stated.
Sure. Any other board members would like to make a comment or ask any questions of Megan with regard to her presentation? Manager Motwani, I see your hand up.
Thank you. I want to first acknowledge and recognize the difficulty of community engagement, especially ongoing community engagement and getting folks to return to meetings and carry on sort of mini longitudinal feedback during the pandemic environment. And with that said, certainly always in favor of continuous improvement when it comes to digging in as much as we can to have equitable community representation. And I also really appreciated a lot of the recommendations here and the profundity of the same, which also means that I'd love to see some of those recommendations written, because I'd love to dig into them more. I appreciated the granularity, frankly. And the question I have is it's pretty simple. I was just curious about the number of unique individuals who were interviewed. I appreciated that, frontline staff were interviewed, and as well, as ostensibly community members were being interviewed by CHWs. And just wondering if we have numbers on maybe how many community members and how many frontline staff were able to share, if we have any demographics around that that may be able to help sort of satisfy some of Manager Valadez's concerns.
Thank you, Manager Motwani. Chair Greenberg.
Yes, thank you very much. I want to thank all those who participated in this important work, and the data I think is very important, and there were some very important recommendations because we know that we need to prepare for the future, whatever it may hold. I do think it would be very helpful to, since we are being data driven, and I really appreciate that, to have some of this, as was mentioned, background data. So I think that would be helpful. Thank you so much for all your hard work.
Thank you, Chair Greenberg. Any other members? I would like to agree with both Manager Motwani and Chair Greenberg that the recommendations were compelling. I know that I've sort of seen a number of disasters in my lifetime, all affecting different parts of the population, some more inequitable than others. And I think that as we look at what has been done afterwards and try to prepare for the next disaster, we don't always get it right, and we don't always address those inequities that we saw. So I think that your time and your efforts that you put into this have been excellent, and I just want to show my appreciation. Any other board members? Then I will ask for Mike, if you still would like to make a comment. I'd like to recognize you at this time.
Thank you, Mr. Chair. Thank you. So Manager Valdez, I hear you, and I think if I may, I'm going to ask you to direct everything that you just said to me, because staff and consequently the Equity Policy Council and the Pandemic Equity Committee, to be more precise, did exactly as I asked them to do. And I'm the one that asked the question, what is pandemic equity? What does it mean? So if, again, you need to channel that towards me. So on behalf of all the administrators and bureaucrats on the line, I want to commend them for the work that they've done, because it is to, who else is doing this, right? But I think it's important when we think about the people that we serve, that we just don't let these moments pass us by, then they get lost in social media posts and probably ill-written history that doesn't really capture the suffering that occurred at a very individual level. And that's my concern here. And like Dr. Bell had said, having been through a number of disasters and seen how it's has been handled in different counties over the years, the one unifying theme post-disaster is that those people that really understand the lessons and dive deep into this and make changes to get ready for the next one are those communities that harden themselves and do address equity in increasing proportions, inequity, and with increasing measure, so that people don't suffer. Not as much as they did before, but never is enough. We can do enough to alleviate the level of suffering. That's what this is deep for us. The other thing I'll say is the Equity Policy Council, and specifically the Pandemic Equity Committee, some of the members are on the line here today, and I want to thank them personally for your busy lives, personally, professionally. You've allocated some time to us. You are representative of a very diverse and inclusive community, and I thank you for being at the table. And if you haven't lived the experiences, you've dedicated your professional lives and volunteer lives to serving those that are currently living the experience, and that's powerful. And I think that does bring a perspective and voice to the table, but by any means, that's not the only voice that we listen to here at Central Health, Manager Valadez, because we have conversations with many groups, many individuals. Sometimes it's at a vaccine event. Sometimes it's at a clinic. Sometimes it's on Zoom calls like this. But we connect with so many different diverse groups of people that the point that I'm making is that our knowledge base, our level of understanding, our empathy that we have as bureaucrats and administrators goes far beyond any council or committee. And I think that's important to note. Lastly, as Megan indicated, this is a multi-year plan. Mm-hmm. And there are so many more next steps and so many more bites at the apple that we'll have on this. And so we're going to take some of the questions here and the requests that have been posed and some of the issues and incorporate that into our future work stream, because we're not done with this by any stretch of the imagination. So thank you, members, for indulging me.
Thank you, Mr. Giesland. I appreciate those comments. Manager Valadez.
Yes, sir. Thank you very much, President Giesland. I don't want you to get, that's why I preface my count.
It's Mike. It's Mike.
I'm sorry, Mike, thank you. I prefaced my comments. I didn't want anybody to feel that they needed to get defensive and they needed to comment. But I am telling you, I live in that community and I have worked most of the disasters for many, many years. And I can tell you in talking to the people, Latinos, Mexicanos, Asians, Blacks, everybody else that we have helped over the past 40 years that I have been here, that we have learned that if we're not at the table, if we are the people who are not at the table talking about or driving or directing the conversation, the analysis, the recommendations that need to be developed and put forth, then we're out, okay? It's easy for people who are in the realm of writing grants, of writing recommendations, of dealing with politicians to be able to write a lot of things. But when you are someone who lives in that world, has seen the inequity, is continuing to live in even more intense inequities, as we are as Latino population and minority population, a non-English speaking population, and a poverty population, not having them at the table is very, very disrespectful to me. And even if you have a couple of seats allocated to people who can bring forth their concerns from the community, I think it's necessary to start thinking and reshaping our how we'll do this and what will we recommend culture. So I appreciate your comments, Mike. I hear you and I know you hear me and you know where I'm coming from. And anybody who knows me knows where I'm coming from. There is no disrespect, no malintent, nothing intended. I just want it to be understood and understood clearly that our poverty population and our hardest hit populations that do speak or don't speak English are not always heard. And unless they are at the table, they won't be. Thank you.
Thank you, Manager Valadez.
Understood. Thank you.
Thank you, Mr. Giesland. Okay, any other comments or questions from board members? Hearing none, I am going to go back to our public comment period, and I am going to turn it over to Yvonne. I know we have one member who wanted to speak that is now present on the call. The other may also be on present, and I'm not sure I see them. But Yvonne?
That's right, Mr. Chair. We do have Paul Saldana, who has joined us, and he is with the Austin Latino Coalition. Paul, you have 3 minutes, and if you can please unmute yourself and give us your comment. Thank you for being here.
Thank you, everybody. Thanks for having me. I had submitted a request to speak on item number 5. I didn't hear back from any of your staff, but I'm happy to be on at this time. I don't know exactly what it is you're going to be presenting on item number 5, so I'll go ahead and just take this opportunity to speak. I do want to address, though, however, the conversation that just concluded, and that is just an important reminder that the definition of equity and equal should really be based upon the lived experiences of the people that Central Health and Community Care serves. It should never be based on what government believes equity and equal is. It should be based on the lived experiences of the people you serve. So I want to just go on the record and say that. Last night, we did have representatives, Mr. Giesland and Jason Barla-Celso, who joined representatives from the Austin Latino Coalition, the Del Valley Community Coalition, Judge Andy Brown, Mayor Adler, City Manager Spencer Cronk, Constable Morales, to have a conversation about what the latest is, or what the actual comprehensive vaccine distribution plan is for the Eastern Crescent. Again, this week we were reminded by several news stories about the ongoing inequities regarding the distribution of vaccines and the disparities. There was also an opinion that was written by one of our members of the coalition, Matt Worthington, who's also with the UT LBJ School, wrote an op-ed about the urgent need for us to have vaccine equity And he reminded us that leaders really need to use geography as a prioritization tool to reduce these inequities and make it easier for folks to receive their vaccinations. And he cited very important data that I want to share with you as it relates to the Dove Spring Recreation Center Vaccine Hub. While it's located in 78744, where 74% of residents are Hispanic, that's my zip code, out of the 25,000 doses that were administered at this site between January 5th and March 6th, only 850 doses were administered to 787 residents. The top 5 zip codes for doses administered at Dove Springs were all predominantly white areas west of I-35. And so this is no surprise to all of us. And I think we still have a lot of work to do. One of the reasons we called that meeting last night was that was the first time we had reps from the city, the county, Central Health, Community Care, CODA in the same room together. And what we're seeing is that there are still major disparities on what's happening at CODA. That's what's happening by Austin Public Health. And I understand that now there's the dashboard has been updated to now include Community Care's data. So the number now looks like it's 285,000 people have received vaccines, but nearly 50% of those who received the vaccine are white. And you all know who your database, who your clients are. So there continues to be that disparity and disconnect. So I'll stop there. Other than I look forward to hearing what these presentations are. I'm still not clear and confused, a little confused about exactly what your strategies are going to be to address these inequities. But there's a major disconnect. There's a major disconnect, and there doesn't appear to be a coordinated effort between Austin Public Health, the city, the county, and your organizations. And unfortunately, the communities that continue to lose out and continue to be disproportionately impacted negatively are our Latino and African American communities. So it's my hope that we can all get on the same page. We're 6 months into the vaccination process. We have lost 830 people in Austin, Travis County, 50% from my community. 408 people from our Latino community have died. And so I think we have unfortunately lost some people because a lot of our folks in our community are still waiting to get the vaccine. And so we need your help. We need your advocacy. We need your support to be able to make sure that our people are getting access to the vaccines. Thank you.
Thank you very much, Mr. Saldana. And we appreciate your comments. We appreciate your participation in our committee, and welcome you back at any point in time. You made some extremely valid points that we need to consider as we move forward in this issue. Thank you. Thank you for your time.
Thank you, Paul.
Thank you, Paul, and thank you, Mr. Chair. We have Claudia Zapata, who also signed up to speak, and I don't believe the person on the iPhone is that person. And I know who the person on the telephone is, on the cell phone, and that's not them. So I'm gonna turn it over to you, Mr. Chair.
Thank you, Yvonne. I appreciate it. We will move on with our agenda then. Agenda item number 3 is to receive an update on FY 2021 systems planning priority related to dialysis. And our presenters will be Megan Clark, Jesse Patton-Levine, and Frank Prictus. And I know I mispronounced your name, Frank. I am so sorry.
No worries. Won't be the first time.
All right, thank you. Let me get my screen up here.
Am I frozen or is Megan frozen?
Hello, can you guys hear me?
Now I do.
Yeah, I think it was Megan.
Okay, sorry about that. I'll stay off video. Can you guys see my presentation in presenter view?
Yes, we
Yes.
can.
Okay.
We can't now.
Not anymore.
You pulled it down, I think.
All right, let's try one more time.
I can see it now.
Okay, perfect. Thank you everybody for joining us today for this update on the Dialysis Transitional Program. My name is Megan Clark. I am a Service Delivery Operations Manager with Central Health. I help oversee and support the nephrology service line, and then also helping support the Central Health Transitional Dialysis Program project. And joining me, I have Frank and Jesse, who I will allow for them to introduce themselves.
Frank Preckvies here, is Senior Project Manager that I've been working on this dialysis transitional program for the better part of about 8 months now with Megan.
Hi, everyone. I'm Jessie Patton-Levine, Senior Epidemiologist working at Central Health in the Analytics and Reporting group. I've been supporting this work around dialysis and chronic kidney disease for about over a year. And so I'm here for data support and to talk about the data.
Great, thank you. So we wanted to start off with a timeline just to show you guys how long we've truly been working towards this goal. As you can see, in early 2018 and 19, the CHAP expansion program was established, and then funding was also increased to allow for more high-risk patients to transition over to that program. And then in early 2018, our case management team started their efforts of transitioning patients over to the American Kidney Fund, who also provides premium assistance to patients in need of dialysis, which will go into a little bit more detail in a couple of slides on how instrumental this piece has been for us. In late 2019, Central Health, in partnership with Community Care, helped recruit Dr. Novick, who has really been a subject matter expert for us. Her passion and expertise has really helped shape this dialysis program that I'm going to present to you guys today, and I'll go in a little bit more detail about her as well. So in early 2020, with Jesse, we started kind of diving in deep in the dialysis exploration, really talking to experts in the community, different dialysis partners in the communities, nephrologists, and so on, to help develop a really comprehensive business case to present to the Central Health team, which was ultimately approved. We then started doing some further work on identifying partners that would be interested in working with us. And in the meantime, I want to highlight as well that Community Care opened up their own nephrology clinic several times a month as well, that's supported by Dr. Novick. So any added access is great for our patients. And then current state, we'll go into some of the dashboard work that we're developing to help us make some real-time decisions. And then in a couple of months, we hope to get some partner contracts executed, as well as expand some transportation contracts, and then go live with our dialysis services. So next slide, I wanted to show this data set to you guys. When we first started sitting down to really dive into the work, this is kind of what we looked at first. We wanted to get a really good idea of the current state of our MAP population and where they fell into the different kidney disease stages. So I'll turn it over to Jesse to go into a little bit more detail.
Hi, everyone. So what you're looking at here are the total number of unique patients, whether they were enrolled in MAP, MAP Basic, or utilizing sliding fee scale services in that given year. They're split out by stage. So end-stage renal disease is on the very left, and then we progress to lower stages as you move to the right. You can see for FY 2021, our counts are lower, and that represents the fact that we are still mid-year. This was data that I believe was run as of the early April. I also want to point out that these are not necessarily active patients as of today. I'll call out that currently here we report 80 for fiscal year 2021, and when we looked at the beginning of April, there were 36 MAP patients with end-stage renal disease and 10 who are MAP basic. A little background just on how we source this data. We looked at diagnoses codes present in our claims, in our data, EHR data that we get from the providers, anything that was available to us.
Thanks, Jesse. So we wanted to also give you guys some background on services that our patients currently have access to. So from a nephrology care standpoint, Seton McCarthy offers nephrology care, as well as I mentioned, Community Care set up a clinic in September 2020. And again, Dr. Novick operates at the Community Care Clinic. And just a little background on Dr. Novick, we helped recruit her in partnership with Central Health and Community Care. She has a medical social worker background as well as an epidemiology background. And she's truly passionate about combining her social worker background with being a physician to really address complex medical issues in the patient's environment. So again, she's been instrumental in helping us truly understand what a comprehensive dialysis program should look like. And we look forward to even further conversations to what do we do to prevent the progression of our patients from reaching dialysis. And then some of the wraparound services that are available to our patients include dietitian services as well as pharmacy services. And then I want to give a really big kudos to our case management team at Central Health and then also at our FQHC partners. They have been key to moving patients into other coverage programs. We mentioned the CHAP program and the American Kidney Fund program, but truly it's been their work reaching out to patients, identifying not only transitioning them, but other services that they may need access to. So really good work by those teams. And then the current state of dialysis for our patients. So in the state of Texas, I'm sure you guys all know, for undocumented and uninsured individuals, the only access is the ER. Unless they enroll into another program. And as you can see, $21.8 million was spent in 2017 just for uninsured hemodialysis visits. And for our MAP population, you guys know it's not a MAP benefit. Our patients do use the ER. It's termed compassionate dialysis when they go. And one thing we did learn that we did want to point out, Seton is offering some vascular access points for our patients, which we think is really good. Vascular access points are kind of the gold standard. So some of our patients do have access to that. But what has been really key for our patients, again, I'll mention, is them transitioning to other coverage programs. And so I'll turn it over to Frank, who will talk about kind of what it really means for our patients and then past and current enrollment efforts.
Thank you, Megan. So this is an overall depiction of the journey of a MAP patient or a patient that was diagnosed with ESRD basically throughout the year. So whenever a patient is diagnosed with ESRD, they're introduced into our case management and our medical management team. So at that point, we have a social worker address and assess their program eligibility, whether it be for one of those programs Megan mentioned, Medicare, the American Kidney Fund, or our CHAP program, which I have actually personally worked on in our eligibility before I moved over here. So I can speak to that. It's a very comprehensive and a collaborative effort for those involved to make sure that our patients are provided the best coverage that helps them with their dialysis needs. And if not, they can re-enroll back in MAP. So as you can see from from left to right, they'll assess the program eligibility. They will connect them to someone who can assist them actually enroll them in that coverage. And then they will actually get the proper assistance in enrolling into one of those coverage programs that I'd mentioned earlier. So where they can actually transition to another payer and receive outpatient dialysis. And if not, again, they can re-enroll in MAP. And the most important thing here is I want to mention that it's not for any financial reasons primarily. This is to get patients onto a program that covers their needs, especially with dialysis. They have so many additional health needs aside from that hemodialysis that sometimes it's very valuable for these patients to have that full comprehensive coverage where they can have access to everything that they may need. And so down here on the bottom right, you can see how many patients we have actually transitioned over the years into the various programs that we run here at the CHAP, and obviously the American Kidney Fund that we refer over to Fresenius to help us enroll in those programs. But as you can see, in 2018, we were able to transition 17 to that Blue Cross Blue Care program. And then in 2019, we had a little less than CHAP. This is our first year getting the CHAP expansion program underway, so it was a little bit difficult, it looked like, to get some folks enrolled into that program. But as you can see, we're doing better in subsequent years. And then finally, again, in the last few years with the AKF, you can see some additional jumps in enrollment as well. So as you can see, this has been a very successful effort on our part throughout multiple departments at Central Health, starting with our medical management, all through our eligibility, and now in our service delivery department.
Thanks, Rick. And then I'll just make a special note. The 2021 at the bottom is the special enrollment period that was opened up this year. So we continue our efforts even this year during that special enrollment. In this slide, I thought it was important for us to just touch on a little bit about the quality of life. I think this brings true meaning on the importance of this program. So as you can see on the slide, the 5-year relative mortality rate for patients who only receive emergency dialysis is 14-fold greater than those who receive standard hemodialysis. And they spend 10 times more time in the hospital than in the outpatient setting where they really should be. And then this was from a study that Dr. Novick shared with us, which we would say echoes some of the sentiments that our patients are feeling. But patients indicated that they will wait. They will wait until their symptoms are severe enough to put them at risk for death. When going to the ER, they have to meet certain criteria before they're deemed an emergency and given hemodialysis in the hospital. So they will wait. And if they're admitted, they're unable to work. They have to plan for childcare, which we know can be a burden for a lot of our patients. Again, from a psychosocial aspect, the recurrent fear of dying, insomnia, anxiety, all of those things our patients are experiencing. And then their families are having to witness this. Seeing their family member decline basically right in front of them. And so this really brings kind of everything full circle on why we need to offer these services to our patients or move them to a coverage program that would allow them to have access to these services. And then at the end, I'll mention too that even in this survey, despite some of the things that were mentioned, they expressed an appreciation for the care because it would not be available in their own country. So where we are today, so we are kind of in the midst of standing up this program, and we wanted to create a real-time dashboard really that would allow anyone who's kind of working with this program, especially our case management team, to have the ability to make real-time decisions and see who all has end-stage renal disease or where they are in their CKD stage. And I'll turn it over to Jesse to kind of go over kind of what this dashboard looks like now and what we hope to develop in the future.
Sure, and if you want to go to the next slide, Megan, you can do that. So this is just kind of the first prototype of the dashboard, and this is just one sheet. What you're looking at here on the upper left that's all blacked out is individual patient information, which we're obviously not sharing with the group today, in addition to some large aggregate breakdowns by different demographic characteristics. So it's twofold. One is assisting with medical management staff, having a place where we can kind of pull in a lot of the data that they themselves are collecting, in addition to key information from eligibility, and for them to be able to kind of go in and help monitor those patients. A function that we have in development, and it's kind of in the middle of the page there's a ranking next to that big black box. And that is something that is in development. We are trying to work on a risk prediction of patients who would progress from a lower severity CKD stage onward to end-stage renal disease. Currently, we are using some model coefficients that are published via some other work, via the literature. Right now, I think we're using a 2-factor equation that incorporates age and sex, and we could also incorporate lab values where needed. But I think the big development that we're working on really is our staff in the analytics department, our biostatistician and our data scientists are both collaborating and working on various modeling products to, using our own data. So we're basically modeling to see of our patients, in the past who have progressed to end-stage renal disease, can we use that information to predict patients today who might progress further in the disease? Kind of a further added benefit to that is, eventually it's not just looking from a CKD stage to end-stage renal disease, but also progression across the stages. So eventually, our goal here would be to slow and prevent the further disease progression there. But then also obviously having more information available may help in accessing care earlier for some of these patients.
Thanks, Jessie. So what are the components of our transitional dialysis program? So of course, dialysis, we want to have in-center, in-home dialysis. We realize that home dialysis might be more beneficial for patients who may be more mobile, have support at home, are looking to get back to work or work part-time. So we definitely want to make sure both of those options are available. Vascular access, which I mentioned a little bit earlier, we want to make sure that that pathway is definitely available. Catheters are more short-term use, and then AV fistulas, like I mentioned, are the gold standard for long-term dialysis. And then of course, case management, we've already mentioned how key they've been, and we want to continue to make sure that that program stays robust and the resources are there to support this program. And then also transportation, going to dialysis 3 times a week can be a lot for a lot of individuals. So making sure we have those different components in place to support this program will be key. And then our second to last slide is potential partnerships. And this is not a final list by no means. We're not asking for any approvals. These are just individuals we've talked to in the community that have expressed an initial interest to work with us. So you can see from an in-center perspective, Fresenius and Satellite, and then from a physician management perspective, Austin Kidney Associates, and then also ADC. You can see on the map off to the right, kind of the different locations of the in-center locations. And again, it's not in our focus areas, but it is spread pretty throughout I-35, which we think with the transportation access that we would have available, our patients should be able to access these sites. And then I will end kind of on just this illustration. It's just really kind of a recap of what we just talked about. So the current state, just our patients are going straight to the hospital for all their dialysis needs. And then we hope to develop a comprehensive program that includes, again, the catheter access, the fistula access, the in-center and the home dialysis access. And then hopefully through our long-term planning at some point, we can discuss the kidney transplant needs. So I will end here and open it up to anyone on the Central Health team that might have some comments they want to add.
Okay, any of the other presenters have any additional information that they'd like to add before I open it up for the board members? Okay, board members, any comments, questions, or concerns? Manager Valadez?
I can't say thank you and thank you and thank you enough to talking about the cost of diabetes, to kidney damage, to your body damage, to families, the psychological and psychiatric traumas and depression and impacts on the family members of those surrounding the person who is ill. It looks like you've got it pretty much covered, except I didn't really see any psychological or psychiatric support for the patient once they get diagnosed for dialysis, and how we're dealing, how the families of these patients are being brought into that circle of care that they need to have, an understanding of what a good care program looks like, what a good nutrition looks like, you know, appropriate behaviors, all those things. And I just wanted to know if that is in fact going to be a component. I see that you had a sheet on it, but I didn't see how it was going to, and how it was going to be implemented and where was it going to be implemented. And I will agree with you 1,000%. I saw the numbers, the demographics, majority undocumented, majority non-English speaker. And those are the ones that have the least access to resources, and they're the ones that are dying in numbers, huge numbers. And, you know, I would love to see a day when we have much more than 17 or 21 or 25 that we're taking care of. But I can't thank you all enough, each and every one of you, for what you are doing here today. Thank you.
Thank you, Manager Valadez. Any other? Well, I think there was a question.
The question was about the psychological and
add.
psychiatric wraparound. When, where, and when is it introduced? And if so, is it only to the patient or to the entire family?
Thank you. Megan, did you want to address that, or another staff member? Or?
Sure. So some of those services are offered at the dialysis center. So when they transition, they would get the full wraparound services that the dialysis center offers. I think you make a great point. I think we can touch base with our FQHC partners to see what type of wraparound services, if we know those patients are transitioning, or even if they're in the CKD stage, what type of support that they're going to get.
And I just want to follow up one quick one. So as they enter our system, are we, once we realize they're close to the middle or end of kidney failure, are we putting them in CHAP or are we not? Since MAP right now doesn't have an in-place system, what are we doing to make sure that they get covered?
Mr. Morgan, John?
I wanted to add first to Manager Valadez's first point, which I think is a great one, about psychiatric and counseling services. I think Megan was exactly right, but I do want to be clear that those services largely don't take place today because the majority of our patients are only accessing dialysis on an emergency basis. So I think that's part of the benefit of the wraparound solution that our team has developed, and clearly they've put a lot of thought and time into this, and spent several years and hundreds of hours trying to put these different pieces in place leading up to where we are now. But thank you for the feedback on that. I think it is an area that we can go back and ensure that is going to be comprehensive, because just like we talked about in surgical podiatry, these are patients that are going through a pretty traumatic transition and need family support, need clinical support, behavioral health support moving forward. On your second question about CHAP, I think we have and Megan will correct me for sure, I think we kind of have a priority order that we try to use when we're thinking about what we are transitioning patients out of this program into. First is Medicare. If you're a U.S. citizen documented, you qualify likely for Medicare with this as a disabling condition. Depending on your work credits for Medicare, then Medicaid may be a secondary option, and we then look at Medicaid as our second tier. We also look at the American Kidney Fund Fresenius program through Blue Cross Blue Shield as our kind of third tier there. Again, with Central Health as a payer of last resort, we try to exhaust these other resources first, and then use Sendero and the CHAP expansion program as that fourth piece. It's important to note that when we are transitioning these patients to Sendero and the high risk program, that a dialysis or end-stage renal disease diagnosis by itself does not typically make the patient automatically a contributor from a financial standpoint on the Sendero side. These can be incredibly expensive patients, and the risk premiums or risk subsidies don't necessarily account for it. But one of the points that we get through Medicare, through Medicaid, potentially through Blue Cross, and even through Sendero is sometimes these patients will have access to things like kidney transplants, like the slide shows, where they're getting curative treatment for their kidney failure, and that's a aspect that we do not offer today in the MAP program. So that's a pretty big benefit, but it is a high cost solution in the short run for any of the plans that we would be enrolling these patients into.
Thank you, John. I appreciate that. Manager Valadez, I'm going to make a point first.
No problem.
And I will call you. Thank you, John, for sort of outlining the fact that, these individuals are extremely expensive, but they don't always meet the criteria for what we call at Sendero high risk, and thus don't necessarily pull down the risk adjustment that's needed to continue to sustain Sendero. So it's a delicate balance as we look at being able to put individuals on Sendero, and I appreciate you bringing that up. Megan, I just wanted to say too that I appreciate this last chart that you put up, because it really outlines the issues of the fact that many of our patients have no other alternative but to go to the hospital. And we need to fix that. We know that, first of all, that's the most expensive. And in these patients, it really is sort of the last resort. And I'd like to see us continue to move a patient through the system and hopefully slow down the progression of their chronic kidney disease to allow them to have a better quality of life for a longer period of time. So I know you meant this as a summary, but it really does outline what we're attempting to do with our dialysis program. And thank you for that. Before I get to you, Manager Valadez, Manager Matwani, I thought I saw a hand. Am I right or am I wrong? It was up there very briefly, but Manager Matwani.
Thank you, Chair. And I really, really appreciated this presentation as well. On a lot of levels, I think institutionally, this is God's work as much as I've ever seen it. As Manager Valadez did a great job of expressing, to be at this stage of illness with not many doors open to treatment. It's nearly inconceivable unless you're there, unless someone you love is there or has been there, or unless you've been close to it. And it's very meaningful. And on that note, I want to express how much I value that this presentation seems just so human-centered. Perhaps one of the best I've ever seen, with so many humanizing factors framing the context for ongoing strategies and incentives, where often, strategies and incentives and dollars are divorced from so many of the humanizing factors when, institutional decisions have to be made around sustainability and caring for, populations at large. I think the characterization of fear of death and its cascading effects on families and loved ones really brings it home. And again, I think the incorporation of case management strategies as integral to the strategic work is representative of that human-centeredness. And on the notion of strategies, I feel so confident in the team that's working on it uniquely. I mean, outside of course, the physician experts and nephrologists, but the data and analytics and modeling and data scientists team who are working on it. I feel so confident in just what we've seen now in early days, the ability to really be as ahead of it as possible and manage our strategies in a way that I think results in the best outcomes from a human-centered standpoint. And, finally, just really, really being able to get better treatment for folks earlier and recognizing the challenges that folks who have different paperwork have. And, again, with the number of physicians and data scientists in the room, I want to be careful in saying this, but, looking at some of the helpful visualizations they gave us, particularly the one with, the pies and bars, the mixed bars all together, it may be even good to get that up on the screen for just a second, if possible. It was the dashboard, right? One after, yeah. Just looking at the diagnosis breakdown there, pretty much right before end stage, all of the other stages undocumented is tracking at, 30% or less. But at end stage, pops up to near half. And, again, no one can make a frivolous assumption here, but if somebody is not regularly going to dialysis and only going to the ER, and waiting as long as possible until they have fear of death, there may be a correlation worth exploring. And I thank y'all for such an informative and human-centered presentation.
Thank you, Manager Motwani. Appreciate those comments. And staff, I totally agree with him. It was an excellent presentation from many, many aspects. Manager Valadez, did you have no comments? Okay. So if there are no other, Manager Valadez?
I just want to thank Amit for stating so eloquently those concerns, because I was going to bring up some of them, but thank you. And to thank y'all and thank the team.
Great. Thank you. Okay, hearing no other comments or questions, I would like to go on to agenda item number 4. Receive an update on central health dashboards associated with service level reporting for fiscal year 2021. Members, there's no presentation on this item. The relevant information was provided in the backup, and staff are available to answer any of your questions if you have any. Manager Valadez?
I just had one. I would like to know whether or not they can reintroduce wait time data, because I'm hearing from people that they are having the wait times have extended. They're longer. We have, in some people's opinions, we're going the wrong direction, and I just want that documented. So I'd like for wait time data to be included in our dashboards. Again, remember per diagnosis.
Thank you. Thank you very much.
I don't know if anybody else feels the same way, but I'd like to know so that we can make sure it gets added.
No, I think that's an important data point. We've been working on wait times for a long time. Mr. Morgan, did you have something to add?
My apologies, my internet went out there, so I did not catch Manager Valadez's comments, but Manager Valadez, I'll be happy to follow up with you offline.
Dr. Bell can tell you very quickly.
We were looking at, John, the fact of adding wait times to our dashboard that we received on this particular item. And I thought that was an appropriate request because we work on wait times, and I think Manager Valadez has heard that they are creeping back up. And so it would be nice to have that.
May I ask specific to nephrology or more generally?
No, generally. With respect to from initial response to especially trying to get into specialty care, I've heard that it's really, really bad. Oh, well, yeah, we've given you this, but as we refer you to specialty care, you're going to have to wait 6 months, that kind of thing from people who are our patients. So I'd like for it to be added again. It used to be a huge problem. We thought we had a handle on it before, Jonathan, and now that's not what I'm hearing. So I'd like for that to be documented.
We'll work with Dr. Bell on an appropriate time to update the committee. Thank you.
Thank you.
Thank you, Manager Valadez. Did you have anything, Mr. Giesland? I saw, no? Okay, thank you very much. We will go on to item number 5, receive an update from staff regarding COVID-19 responses. There are a number of staff that are going to present on this. Mike Giesland, Megan Cermak, Ted Burton, Yvonne Davila, Isla Guerra, and Anastasia Sims. So we look forward to hearing it. Mr. Giesland?
Yes, thank you, members. We're going to provide a COVID update. I'm going to tee this up with going back to some comments that were made in prior board meetings and provided in written updates to the board, just to set the stage for this. And then Megan will start us off, and then we'll cover a couple of areas. So remember, whenever a public disaster emergencies are in force, so declared by the governor and then declared locally, there's a series of statutes that start to govern how a disaster response is handled in Texas. And it's the same statute applies to all counties, and it's Chapter 418 of the Government Code. So, but what's interesting about that statute, as well as our own governing statute, Chapter 218, Health and Safety Code, 281, the Health and Safety Code, is that it doesn't really spell out the role for a hospital district. And so what we did at the start of this pandemic is we knew that we had some strengths. And then the question was, okay, what strengths do we deploy and in what directions? Because we know that we want to do, for the sake of the people that we serve, what we can, when we can, where we can, to the best that we can. And, you know, so for instance, you've seen a lot of communications and outreach, not only digitally and paid media, but also with in-person and working with our partners like Communities Coalition for Health and Latino Healthcare Forum to provide that in-person outreach, because we know that not everybody's going to either have connections to the digital world, or perhaps maybe just, you know, overburdened by the regular media. And so having that trusted voice was important to us, but telling those stories in different mediums too. So that's one strength that we have put into play here. Another is, and we'll talk about it later on, is, you know, what we can do as a funder of healthcare to continue to fund healthcare, not only the medical access program, but to support efforts of our enterprise partners, and more recently with reimbursement to incent, and I should use a different term, a payment program to incent certain actions to be able to close the health disparity gap, especially as it relates to vaccines. So we'll cover a number of issues today, but I wanted to just to paint that backdrop that all along our strategy has been, absent a really well-defined statutory role. Again, we took the strengths that we had on the shelf and put them to work. And there's so much more that I'm leaving out. There's been a lot of operational support at PPE events, as well as flu shot events, which was part of this, as you'll recall, response to the pandemic to try to keep the flu cases as low as possible in Travis County. And then obviously with vaccine events. So again, taking our strengths and putting them to work when we can, where we can, to the best of our ability, has been our strategy up to this point. So with that, I will turn it over to Megan.
Okay, thank you. Before I begin, I just want to let the Board of Managers know that some of what I'm about to say is not captured on the slides, and that's because I'm trying to bring you the most timely information. Specifically, the information that's not captured on the slides is this information I just learned from a call with the EOC from noon to 1. So I can follow with what I say in writing in an email to the managers, so you have it all. I'd like to start off, if you can flip to the next slide, please. Thank you. First, I'd like to start by talking about community transmissions and hospitalizations, where we're at. So this week's overall positivity rate is 4.8%. Our positivity rate has been hanging out between 4.5 and 4.6, 4.7, 4.8% for the last 4 weeks. This is essentially good news. As a community, we need to stay at or below 5% for overall transmission. Our daily new COVID cases have been averaging in the low 100s for the past 3 weeks. Our daily new hospital admissions have remained around 19 for the past 3 weeks. Last Friday, APH reported that we had 1 day with only 9 hospital admissions. And this is great news because we have not had a single day of single-digit hospital admissions since September 2020. This week, we also saw the moving average of vent use creep under 20. That's the first time we've seen that since November. And overall, total hospitalizations have been slowly declining for the past 3 weeks. Some other good news is that our total length of hospital stay has reduced by 40%. And we've seen a 63% reduction in mortality rates for people over the age of 65. Having shared some good news, I have a little bit of bad news. And that is we are detecting more and more variants circulating in our community, specifically the UK variant, the California variant, and as of last week, we now have the Brazilian variant detected in our community. Also nationally, we are starting to see some people who are fully vaccinated become hospitalized with another COVID infection. And locally, we have seen 2 such hospitalizations. One of these cases is due to the UK variant. Overall, the picture in our community is very flat right now. There is some thinking, especially shared by Dr. Mark Escott, that this period of flatness could essentially be the plateau or the third surge that we were expecting post spring break, post Easter, because prior to these two activities, we were on a very steady decline. Okay, if you could flip to the next slide, please. So is that the right slide? Mass vaccinations. Yep, mass vaccinations, thank you. So as a community, we are trying to get to 67% of Travis County residents vaccinated in order to reach what's considered herd immunity. That's about 853,459 people. APH reported last week that about over 400,000 people are or will be completely vaccinated upon completion of their second dose. So that's a little bit, right now we're sitting at a little bit over 50% of Travis County residents have been vaccinated. On the other side of the coin, 46% of our community is still vulnerable and have not been vaccinated. When we talk about mass vaccination sites, I'm sorry, and I do want to share that APH has vaccinated a total of 230,000 people. So just they are one vaccine provider, and APH alone has vaccinated over half of the total people vaccinated. When we talk about capacity to vaccinate, through their mass vaccination hubs and smaller vaccination efforts, they have the capacity to vaccinate 30,000 people a week, but that's dependent on vaccine availability. At Delco, they vaccinate 3,500 people a day, 5 days a week. And at Tony Berger, they vaccinate 2,000 people a day, 4 days a week. We also have the continued operation, which is a partnership with Community Care, Ascension Seton, and Travis County, and they vaccinate 10,000 people every weekend. In addition to the mass vaccination hubs, we have our smaller vaccination efforts or our clinic-based vaccination efforts. Community Care specifically runs 2 vaccine sites out of Rosewood, Zaragoza, and Burleson, and now offer vaccines for established patients during appointment times at most community care clinics. Their ability to vaccinate is about to expand. Jason just announced on a call before this that they're looking at vaccine sites in Manor and Pflugerville. As a community, we've been waiting for some mobile vaccine efforts to get their legs beneath them, and there's 2 programs specifically that have launched and are getting a lot of attention. And they're being spearheaded by the UT School of Nursing. They're called VAMOS and VaxNow. The VaxNow program takes the extra dose at the end of the day out of the UT Gregory gym and bring them to people who are homebound. And then the other program, VAMOS, hosts vaccine clinics at local churches. Before I move on to the next slide, I just want to acknowledge too that we as a community are monitoring the situation that's happening with the Johnson & Johnson vaccine. With the potential halt in distribution. However, this will have very little effect on us here locally because all of our mass vaccination efforts rely on Pfizer or Moderna. Okay, next slide, please. Thank you. This is it. So in order to get the best picture of who's being vaccinated in our community, we would need to look at the APH dashboard. So on this dashboard, we have our most combined data. That's who's being vaccinated through the APH mass vaccination sites and smaller sites, and then community care. This includes the information from CODA. Now, unfortunately, I'm moving the mouse on my computer and you can't see that. You have to hover over the race and ethnicity pie charts in order to see who's being vaccinated. On the APH dashboard. So not the most user-friendly, but I can report that as of yesterday, that 40% of the combined people who've been vaccinated are white, 25% are Latino. They do not separate white Latino and then white non-Latino out when APH reports demographics. 13% are Asian, 7% are Black, and 6% are unknown. So if you combine that, approximately 53% of individuals who self-report are minority. Now, if you look at the CUC dashboards, it's a much different picture. 1 second. If you can flip to the next slide, please. This is a Jason Fournier slide that he presented at a community meeting, the Austin Latino Coalition meeting last night. So this is hot off the presses. What he is showing is that at the very top bar graph, or the very top part of this slide, this is what's happening at the community care clinics and at CODA. So 0.5% of the people being vaccinated are American Indian, 10.4% are Asian, 6.1 are African American, 3.7 report being more than one race, 0.5% report Native Hawaiian and other Pacific Islanders, 12.9 unreported race, that's pretty high. 33% are white Latino, 31.1% are white non-Latino, and then 1.8 are white unreported. All in all, if you exclude the white, hold on 1 second, let me make sure I say this correctly. I apologize. This is Jason's slide, and so I want to make sure I get it 100% right. Okay, if you take out all of the white non-Latino and then white unreported, 62.2% of individuals vaccinated self-report as a minority for those who report their race or ethnicity. If you look at the bottom part of this chart, or the bottom part of this screen, this is what's happening just at the community care clinics alone. So you're taking out the CODA data. And with that, 78.3% of individuals vaccinated self-report as a minority for those reporting race or ethnicity. So if you want, I can read that because I know that this is a little squished. 0.2% are American Indian, 3.8 are Asian, 7.7% are African American, 1.3 report more than one race, 0.7% report Native Hawaiian or other Pacific Islanders. This is very high, 21.1% are unreported, 48.1 are white non-Latino, 48.1% are white Latino, 16.2 are white non-Latino, and then 0.9 report white unreported. Okay, next slide, please. This is kind of a long time coming. We've been waiting to talk about standing down the disaster response and moving into non-disaster mode for over a year now. And so finally, these talks have begun, but there's a lot to consider before we can stand down the disaster response. Most of those considerations include, now that we've moved into, now that we have vaccinated phase 1 and phase 2, can the healthcare system absorb phase 3 individuals, so everyone over the age of 16, into their daily or expanded operations? Can vaccine providers meet the demand for children once the EUA is provided? And I'm sorry, I shouldn't use acronyms, the emergency use authorization. Can the healthcare system support vaccines as the mass vaccination hubs begin to phase out? And then the final consideration is the COVID vaccine seasonal? Will it require boosters? And can the boosters address the new strains or variants that we're seeing? With that, I will pass it over to the communications team.
Thank you, Megan. Ted Burton here, Vice President of Communications at Central Health, along with my team, Yvonne Davila, Isela Guerra, and Anastasia Sims. We're pleased to provide you with a brief update on our community engagement, outreach, and communication efforts for the past few months as we continue to respond to the COVID-19 pandemic. Next slide, please. No, this slide, stay here, sorry. Last night, Central Health, Community Care, and Community Coalition for Health, one of our consultants, launched a virtual town hall series called COVID-19 and Our Community: Facts, Myths, and Overcoming Fears. This is a town hall series that's designed to increase awareness about COVID vaccines and testing, address vaccine hesitancy and barriers, and dispel myths and share facts that are preventing communities of color from getting vaccinated. Last night's town hall event featured pastors from 3 local churches with predominantly African-American members. And this strategy follows a model that's being used in cities around the country, in which public health authorities are partnering with communities of faith to reach communities of color. Now, Community Care asked us to assist them with outreach to the African-American community. Jason and Community Care reported at the end of March, they'd vaccinated about 18,000 patients, and nearly 80% of those vaccinated represented communities of color. However, Community Care says that patients who are African-American are lagging in their vaccination rates. So last night, I had the honor of moderating an esteemed panel that included Mayor Adler, Pastor Galen Clark from Greater Mountain Zion Baptist Church, Archbishop Sterling Lands from Greater Calvary Bible Church, Dr. Charles Moody. He is the CEO of Community Coalition for Health, but also a pastor at Rock ATX. Community Care's Dr. Clifton Peel, Jason Fournier, Community Care's CEO, and our own Mike Giesland. We all know, and we've talked a lot about the fact that African Americans and Latinos have been disproportionately impacted by COVID-19 and are much more likely to die or be hospitalized than white people. According to the U.S. Centers for Disease Control, African Americans have the lowest rates of vaccinations among any ethnic group. And there was a recent Kaiser Family Foundation poll that found 35% of Black Americans said they don't plan to get a vaccine, citing fears about safety and concerns about the fact that vaccines are so new and maybe haven't been thoroughly tested. So back to last night, 48 people attended the Facebook Live event and stayed the entire time. And that's really solid. It tells us that the content was compelling and we believe the panelists were engaging. Viewers submitted dozens of questions through Facebook Live, and our panel either answered the questions live or we're going to answer them in follow-up. We have 4 more town halls scheduled between now and June with Black churches. Pastors on the panel, we think, eloquently explained how throughout history the church has served as perhaps the most influential institution in the Black community, with the power to educate, motivate, and create change. And with help from our partner Latino Healthcare Forum, we're planning to replicate this model with churches that have large Latino congregations and faith-based Asian communities as well. We'll have more information on those events. They're in the planning stages. We're right now kind of coming up with a list of churches, and we've reached out to some pastors and some priests of those congregations. And with that, I'm going to turn it over to my colleague, Isela Guerra. Isela?
Thank you, Ted. Next slide, please. Oh, I'm sorry. It was the same slide. Well, I just wanted to talk about our vaccine registration efforts with our partners at Latino Healthcare Forum and Community Coalition for Health. We have collected and connected almost 3,000 individuals without internet access to get vaccines across all of our partners. So names and contact information were collected at PPE distribution events, at food distribution events, and then we were followed up with these individuals and tried to connect them either with community care at CODA, at the Delco Center, at UT Health, and have been pretty successful in connecting these folks to a vaccine. Internally, our team continues to call our MAP members. These MAP members are our most vulnerable, age 55 and older, who may not be as connected to the internet or social media, things like that, and give them information on COVID safety, on vaccine safety, and also just update them on the medical access program, application renewals, things like that, just keeping them engaged and keeping them enrolled for when they do need medical services. Thank you. Yvonne?
Thanks, Isela. Okay, so we are also building on last year's successful outreach efforts, resulting in us partnering with about 935 small businesses, faith-based centers, and apartment complexes. Our outreach vendors that have been mentioned already, Latino Health Forum and Community Coalition for Health, were able to share PPE kits and outreach materials, which included bilingual in English and in Spanish, visually engaging posters and flyers, encouraging people to wash their hands, watch their distance, and wear their masks as part of our multi-agency Protect Yourself, Protect Your Family campaign. This time now, we are building on these efforts, and Latino Healthcare Forum, Community Coalition for Health, and our outreach staff will be sharing bilingual, visually engaging posters and flyers with vaccine facts and information on how to easily access a free vaccine against COVID-19. And so we're taking our messaging on vaccine facts and how to register to get the vaccine and taking it on the road. We've also been, since the vaccine rollout, we've been sharing information on facts and versus myths about the vaccine via a vaccine education flyer. We continue to share weekly emails, and we have a list of about 600 contacts that are really our message amplifiers. These include our community health champions, our advisory committee meetings, our advisory committee members, and then also many of our partners that have agreed to share information with their clients as well. We have about 200 Facebook groups that we continue to share information on a weekly basis. We've also rolled out what we're calling a community outreach partnerships initiative, where we have organizations team up with us and agree on a different level, on different levels of partnership, including either information sharing, warm referrals to eligibility department, or completing MAP applications on behalf of clients. And so this continues, and they're also helping us share information around COVID-19 safety and vaccine education. Next, I'm going to turn it back over to Ted.
Next slide, please. You're looking at our 5th direct mail piece. This has been a series of direct mailers that we've produced and sent out since last summer. We send these to 38,000 MAP member households. And this particular direct mail piece that is going out this week is titled COVID Vaccines Prevent Hospitalization and Death. So the last direct mailer was all about the importance of getting the vaccine when it's your turn. This one includes messages about the vaccine, but also a reminder to keep wearing a mask and avoid crowds until everyone is vaccinated. We have partnered with APH on messaging, and we're both sharing the same stay positive, test negative, get a vaccine message. And I wanted to point out something that we added to the last direct mail piece. You can see the QR code on the right-hand side. We added that last time because we wanted everyone is using smartphones, and QR codes have sort of had a rebirth during COVID-19 because people don't want to touch anything, whether it's a menu or a card or whatever it might be. And this has been successful. The QR code again was added for the first time and resulted in 850 sessions where somebody used the QR code, which takes them to our website, to our COVID-19 website, and they continue to the site and look for information. It also resulted in 584 new visitors to our website, to centralhealth.net, and then 491 people stuck around on our site and explored for more information. So it was interesting to see that this worked. And we're also promoting 311 as the number to call, especially for people who don't have access to technology or cannot go online and make an appointment. If they call 311, an appointment can be made for them. And if they are homebound and don't have transportation, arrangements can be made to bring a vaccine to them. Next slide, please. Anastasia?
Yes. So, as we entered the vaccination phase of the COVID-19 pandemic, it was really important for our department to share factual, science-based vaccine information, both through traditional and social media. We also focused on our Latino and Black populations who we know are more vulnerable to catching COVID-19, more at risk for complications, and more skeptical of the vaccines. Our tactics included pitching press releases, B-roll, and sound bites to news outlets. Also, PSA-styled videos, and we'll show one later on in the presentation, but they were titled, "I'm getting vaccinated because," and "I'm wearing a mask because." Another tactic was radio interviews on KZIFM through our regular show called Central Health Talks. We have vaccine safety messaging, and finally, a public education campaign through digital influencers. So on the left is an example of our Spanish earned media outreach series. In this series, we pitch stories specifically to Spanish news outlets about vaccine safety, about vaccine side effects and hesitancy. This particular story featured Dr. Ana Avalos from Community Care, and other segments have featured Central Health's Ivan Davila, and we have more segments on the horizon. On the right is an example of our radio show, Central Health Talks on KZIFM. During this radio segment, specifically, we addressed vaccine hesitancy in the Black community with Community Care's Dr. Yagoda and Dr. Charles Moody. So overall, our traditional media efforts since January have resulted in 324 media mentions, 456 million people reached, not at one time, but through various segments, and an earned media value equivalency of $11 million. Next slide, please. So from January to March of 2021, Central Health's Twitter and Facebook accounts have achieved almost 1 million impressions and 18,000 engagements. This, of course, includes our viral video tweet, which was titled, "I wear a mask because." This tweet alone almost reached 700,000 impressions and almost 150,000 video views. It was shared by a large number of people, including celebrities like Poet Laureate Amanda Gorman from the Biden inauguration. Brianna, can you show the video? Yes.
I'm wearing my mask.
I'm wearing my mask. I'm wearing a mask.
I'm wearing my mask.
I'm wearing my mask because even though the numbers have dropped, we're still in a pandemic. It's a very low lift action for me to do to keep others safe, and I want to see us get through this successfully.
Because I hate COVID and I want to protect my neighbors.
I'm wearing my mask to protect my people.
Hi, I'm wearing my mask to protect my family.
Because this pandemic is not over.
I know I'm going to wear my mask to protect my friends and family members.
And I'm going to wear my mask to protect my mom and the rest of my family as well. I feel as though since everyone hasn't had the opportunity to get a vaccine just yet, it just makes everybody a little bit more comfortable knowing that if I have a mask, you have a mask, we're both okay.
So we also did a Spanish version of that video, and it's on our YouTube channel. Last, I'll talk about our digital influencers. Central Health is partnering with content creators who have an influential digital presence. And so that's like almost 10,000 followers. Those are the people that we're partnering with. And we're partnering with them to share accurate, factual information about COVID-19 prevention, about vaccines, and about public health information. By identifying and partnering with digital influencers, we're reaching a new target audience through a new platform, mostly Instagram. And this way, we can share clear, direct messaging that equips our followers to know the most recent information about COVID vaccines and the latest about public health. And that concludes my portion.
Thank you, Anastasia. That concludes our portion for communications and community engagement.
Yes, Dr. Bell and members of the committee, and those of you from the public that have joined us, thank you for allowing us to make this presentation. I'll close this out with the Equity Enhancement Payment Program. And the work on this actually started end of January, and then in earnest began talking with the 3 federally qualified health center systems in town, that of course being Community Care, Peoples, and Lone Star. And so what we have is an equity enhancement payment program. And what we were aiming to do is we knew that there was going to be some significant outreach or significant effort or extraordinary effort needed in order to be able to give people access to the vaccine. And while you've seen a very impressive media, not only digital, but also, as Mr. Davila pointed out, partnerships that we have to do in-person relationships, you have to have the access on the other side of that discussion so that it's there for people. Now, what does that mean? It means having hours that fit people's schedules, and that could be inclusive of late evening, weekday, or weekend hours. It could be additional outreach directly from the provider. In other words, what's the trusted voice for a person? While we're working with different organizations to reach out to people, we also know that there is a doctor-patient or a provider-patient relationship that exists within each of our FQHC partnerships. So it could be a meaningful form of outreach coming from the FQHC. It could be assistance to help bridge transportation gaps to get people to a vaccine site or to get the vaccine to them. And the list goes on, and there's several items that we've listed out in the contracts that we hope to incentivize over this time period. For this particular payment program, we're utilizing primary care dollars. For this first phase of it, we're allocating $500,000 towards this. This is in the primary care budgets that this board has approved, and it is consistent with the budget resolution strategic objective that was approved by a majority of the board in, September of 2020. Now, how does this work? There's actually 2 tiers to this payment program. And this is in addition to federally sourced reimbursements that go to the that are paid to the federally FQHCs. So these tiers sit on top of this federal reimbursement. The first tier is at large, and it addresses individuals that are below 200% of the federal poverty level, including MAP and MAP basic patients, but also those individuals that it's reasonable to estimate that they are below 200% of the federal poverty level. And that's at large, regardless of where they live. The second tier, which is cumulative and can be added to the first tier, focuses on the 20 high-risk zip codes that are listed here in this table. And to be able to get to these zip codes, and Sarita Clark-Leach has joined us and can answer some questions, but I'll just hit the high points here, is we took over 88% of Central Health population and figured out, okay, where is that? What zip codes does that encompass? And then if you compare that to concentrations of poverty, large Black and Latino populations, high COVID-19 infection rates, and also the social vulnerability index, which you heard in earlier presentations, it all lines up. And it shouldn't be a surprise to anybody that if you think about where our patient population resides, those are also zip codes that are characterized by these attributes here. So again, we're trying to get to vaccine equity and incentivize actions that will close that gap for the populations that are underserved. Now, with these zip codes, I will point out that the one down there in the right-hand corner with an asterisk, the reason that that's there, it is a downtown unique zip code that's for PO boxes. But within the second tier reimbursement, we also, incentive payment, we will also pay for vaccinating a homeless individual or an individual experiencing homelessness. And so we needed a zip code to be able to capture that. But with that, we're happy to answer any questions on either the prior segments of this presentation or on the Equity Enhancement Payment Program. Thank you.
Thank you, Mr. Giesland, and the other staff. Excellent presentation. Lots going on with COVID and lots changing as we even sit here right now talking about it. So I'd like to open it up for questions from any of the board members or comments. Chair Greenberg, please.
Yes, I would just like to say how much I appreciate Norma's the creativity, what has been over a year of this. And today it has just really shown through and how much you care about equity, about serving those who are under-resourced, helping those debilitating effects of diabetes, and about being creative in community engagement and outreach to really try to the best of our ability to reach those who need our help the most. So I just wanted to thank you. And my internet's rather unstable, so I may have to turn my video off again or I'll freeze up.
Okay. Thank you. Thank you, Chair Bringenberg. Any other comments, questions for the staff? Manager Valadez, and I'll get to you, Sarita. Manager Valadez? Okay. Sarita?
Sure. I just wanted to make a quick comment to address a comment that was made earlier in regard to the CUC vaccination data. And I know Jason isn't here to speak to this, but just to, as he presented his chart, that chart made the point that the white as, as folks identify as white for their race, they can identify also as Latino for their ethnicity. So those groups are not necessarily mutually exclusive. And if we were to look at the proportion of people who identified as white Latino among the total number of people who reported as white in that presentation, the chart that Jason had, there were about 74% of them who actually reported as also Latino. So we have to be really careful when we look at these data to think that we're maybe disregarding those groups who are disproportionately impacted by COVID if we're looking at race without really considering ethnicity as well. And so that's just something that we should always be mindful of when considering these data.
Thank you, Sarita. I appreciate that. That's invaluable as we look at this data and try to get an idea of who it's affecting the most. So I appreciate that. Manager Valadez.
I want to start off by thanking everybody for this work, but I also would like to make a suggestion. I really like that video. Anastasia, is that you? I really like the video. However, let me tell you, my suggestion is that we start putting different
languages. I think yeah, that's a great idea. You froze though.
Yeah, she froze up.
If we're going to concentrate on the other speakers or whatever. However, I have been watching TV, and in TV, you will have English commercials and you will have Spanish commercials in complete Spanish on English TV. Yeah. So I think that we need to show what Central Health population is. And I think that we should be proud of the fact that we've got all these different diverse communities, different language speakers in one ad, and this is who we are, as opposed to all English speakers or all Spanish speakers or all Arabic or all this or all that. No, I like the idea of mixing it all together unless you're targeting something specifically for that medium, okay?
I love that idea.
I like that idea.
That's
Thank you.
my suggestion. If
Thank
you got not noticed any of the car or truck commercials, that's what they're doing. Another thing on the COVID stuff. Yes, we know who the hardest hit and where they reside, and those top 20 zip codes or 20 are zip codes that I've been looking at for as long as I've been in Austin, Texas. And doing enrolling and doing this and advocacy with the school systems and the healthcare system and everything else. So what I'd like to do is thank you, Ted. Thank you, Isela. And I want to thank Yvonne for officially extending the town hall meetings to other than the African-American population. Okay? I think that should be when I have a conversation with Jason, I'm going to ask him, okay, Jason, why are you just asking that we do town hall meetings for the African-American population? Because it should be for everybody, and it should be for all the other populations, and we should be in their church system, their faith-based systems. We have lots of people that are Latino or Spanish speaking or Arabic or whatever. Non-English speakers, we know there are 3 temples that Amit Salahuddin, who I keep throwing his name out, and I'm waiting for somebody to bring him in to work with his population, okay? We know that there are not only Catholic Latinos, but there are Protestant or other Christian faith Latinos. And, you know, I'm not a Jehovah's Witness, but hay muchos testigos de Jehová, okay? So we know that those populations and those faith organizations, the populations are very, very active in their communities. And we should have already, that should have been a duh since day one. And I think, Sherry, you remember, we first had this conversation when we came on the board saying, why aren't we reaching out to all the resource centers and the quality of life commissions and to all the churches? Okay, you know that we have suggested that this is not in 2021 a conversation that we need to have to lower the numbers on COVID. So I thank you for doing that, and I thank you for understanding finally that we have to do that. We've got to go to the other organizations, the other churches, the other populations, not just, you know, whatever. And one more thing, I hope that we consider expanding who we fund to reach out and to walk the neighborhoods and to reach out into these communities to everybody, because, you know, the majority of the people are not enrolled in any plan. We have almost 200,000 people that are uninsured, and that is our population according to 281. We're uninsured, underinsured, and vulnerable populations. And that, to me, we should be looking at the uninsured population as a new priority for us to be able to go into and make sure that they are we capture them and put them in whatever program we can and offer them whatever services we can. I think that's the #1 priority for me. And Mike, I want to thank you for allowing your staff to do this work for us and for Central Health, because I will say this to you, even though you know, it's I brag about Central Health and I brag about community care. No one is doing as good a job, but I'd like to see some real meat put on and reaching out into the uninsured population to expand out access to the Latino population and other populations that don't speak English. I think that's the topic for me, and I want to thank you all.
Thank you very much, Manager Valadez. I appreciate it. Ted, and then I think Mike had a comment. So go ahead, Ted.
Thank you. I just wanted a quick clarification regarding the town halls. Jason Fournier asked us to assist with outreach to reach the African-American community. He did not say go do town halls. So that was the idea that we came up with based on what's happening in communities around the country. It's a best practice. And so now we are looking, and we've always been looking at doing that, not just for Black churches, but for other churches. But we also know it's not a one-size-fits-all approach. So for the Catholic Church, we may have challenges, and I've already experienced it in some of my outreach, where priests may not be willing to be part of a panel, like the pastors of the Black churches that we've already employed. So we've got to look at ways to tweak that. And we're absolutely not just looking at the Catholic Church. We're looking at, you know, non-Catholic, non-denominational Latino churches in our community. So we've got to be smart and flexible and kind of meet them where they are versus telling them to come meet us where we are. But great points, Manager Valadez.
Thank you, Ted. And you know what? I believe that if you were to take a team, one of your cheerleading teams, to go meet with the bishop, with Bishop Vasquez, you would go a long way, because if the bishop is approving what you're doing, then he will send the memo out to all the priests and let the priests know that this is what you have to do. And the other congregations, the same thing goes. Look for either their reverend, or if they have a top dog within their population, that's who you go to. You don't, you know, you know, we have Frank Fuentes in the Austin Latino Coalition, who's the big Catholic go-to guy, and he's very good friends with the bishop. Make sure you talk to him, because he's getting shots from the state, okay, and he's giving them and he's working his population in the churches. Okay, he had to get permission from somewhere. And so we need to use Frank Fuentes and the others of the coalition to be doing that work. If there's money around for them, do it. And if there's vaccines to be had and we just need people, well, you know, the people we need to put the shots in the arms, let's pay them, because that's what we need to be doing.
Thank you, Manager Valadez. I appreciate that.
Thank you.
Mike, did you have something that you wanted to add?
Actually, Ted covered the points, and it's not an or, it's an and. And realizing that there are many diverse and wonderfully diverse groups that we work with. There's so much outreach that we can continue doing, and we're going to continue to innovate, you know, as the team has just done so remarkably well. But by all means, it's not an or, it's an and so we're here. Thank you.
Thank you, Mike. And Manager Valadez, wait a minute, I just want to say this was supposed to be our short meeting, all right? So I want to preface that before you start. I'll let you make your comment. Thank you.
I promise you 30 seconds. I just want to make sure that I can find out if somebody will talk to me as to where we are with HAM. I'd like to know. Please, somebody let me know. Thank you.
Okay. Any other comments, questions, concerns? Thank you very much, members, and thank you, Ted, and everyone else who had that presentation with regard to COVID. Excellent. The outreach was fantastic. I always get a kick out of those videos. So you guys do an excellent job. Appreciate it. All right. Final agenda item is to confirm the next Strategic Planning Committee meeting date, time, and location. Managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled for Wednesday, May 12, 2021 at 1 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. At this time, I'm ready to accept a motion for adjournment. Manager Valadez?
Move to adjourn.
Moves adjournment. Do I have a second? Anybody give me a second? Manager Matwani, a second. Anybody opposed? Hearing no opposition, we are adjourned. Thank you very much, folks. Appreciate it. Appreciate your time.
Thank you all.
And soon. Bye.
Thank you, members.